Assalamu alaikum. Today I'm going to read AKP clinical case number 21, that is an infant with hypotonia, developmental delay, and small hands and feet. This 4 months old boy presents with hypotonia, developmental delay, dysmorphic facial features like almond shaped eyes, narrow nasal bridge, downturned mouth, poor feeding, faulting growth, and small genitalia. These findings are suggestive of Prader-Willi syndrome. Prader-Willi syndrome is a rare genetic disorder that affects multiple systems of the body, resulting in a characteristic pattern of symptoms that evolve with age. It occurs due to the loss of function of specific genes on paternal copy of chromosome 15, Q11, and Q13. This genetic anomaly can arise from three main mechanisms. Number 1, paternal chromosomal deletion. Number 2, maternal uniparental disomy. Number 3, imprinting defects. 70% of cases from paternal chromosomal deletion, that is, a deletion on the paternal copy of chromosome 15 in the Q11 and Q13 region. 25% of cases from maternal uniparental disomy. The child inherits two copies of chromosome 15 from the mother and none from the father. And from imprinting defects, 5% of cases, that is an epigenetic error in the paternal chromosome that causes the genes to behave as if they were maternally inherited. The syndrome affects approximately 1 in 15,000 to 1 in 22,000 live births and is equally common in males and females. Prader-Willi syndrome has distinct features that changes as a person grows. In infancy, one of the first signs is severe low muscle tone or hypotonia, which makes babies appear floppy. This low muscle tone comes from the brain and is noticeable from birth. Even though their reflexes are present, they are weak. Because of this, affected infants struggle with feeding due to a poor sucking reflex, which leads to difficulties in gaining weight and growing properly. Babies with Prader-Willi syndrome also have some recognizable facial features such as almond-shaped eyes, a narrow nasal bridge, and a thin upper lip that turn downward. Another significant feature in infancy is hypogonadism. Boys may have small genitalia, while girls may have underdeveloped genitalia. Babies with Prader-Willi syndrome often reach developmental milestones like sitting or walking later than other children because of their low muscle tone. Additionally, poor feeding during infancy contributes to slower growth overall. As children with Prader-Willi syndrome grow older, their symptoms begin to change between the ages of 1 and 6. Their initial feeding difficulties are replaced by a persistent and excessive appetite known as hyperphagia. This means that they never feel full, a problem caused by dysfunction in the part of the brain that control hunger. If their food intake is not strictly monitored, this can lead to rapid weight gain and obesity. Along with their eating problems, many children with Prader-Willi syndrome face behavioral changes. They may have frequent temper tantrums, stubborn attitude, and manipulative tendencies, particularly related to food. However, they are often described as affectionate and kind, although some may display obsessive compulsive behavior. Developmentally, many children with Prader-Willi syndrome have moderate intellectual disabilities and learning difficulties. They also tend to have small hands and feet, a feature that becomes more noticeable as they grow older. Hormonal issues such as growth hormone deficiency contribute to short stature and poor muscle development. Sleep problems are also common in this age, including central sleep apnea and obstructive sleep apnea, which can worsen if the child becomes obese. When children with Prader-Willi syndrome reach adolescence and adulthood, additional challenges arise. Puberty is often delayed or incomplete due to persistent hypogonadism. For boys, this may mean they have a high-pitched voice, very little or no facial or pubic hair, and a small genitalia. For girls, it often means they don't start menstruating, a condition called primary amenorrhea. Most individuals with Prader-Willi syndrome are infertile, although there have been rare cases of pregnancy in women with the condition. Obesity continues to be a significant issue in adulthood, particularly if hyperphagia is not managed. This can lead to complications like type 2 diabetes, high blood pressure, and heart disease. In addition, hormonal problems such as growth hormone deficiency and hypogonadism increases the risk of osteoporosis, a condition where the bones becomes weak and are more likely to break. Adults with Prader-Willi syndrome often face behavioral and mental health challenges, including anxiety, obsessive compulsive tendencies, and mood swings. which can worsen over time. Interestingly, many individuals with Prader-Willi syndrome have a reduced sensitivity to pain, which means they may not notice serious injuries like fractures. This lack of pain recognition can delay treatment for medical problems. So, when diagnosing Prader-Willi syndrome involves looking for specific signs and symptoms during different stages of life. As we already discussed, in infancy, doctors look for issues like low muscle tone, feeding difficulties, distinct facial features, underdeveloped genitalia, and delayed development. As the child grows, excessive appetite and rapid weight gain often become noticeable, along with behavioral challenges and learning difficulties. To confirm the diagnosis, genetic testing is essential. This typically involves DNA methylation test, which identifies the absence of active paternal genes on a specific part of chromosome 15 called 15q11 and q13. By managing Prader-Willi syndrome requires a team of specialists working together to address the many challenges associated with the condition. Since this syndrome affects physical, developmental, and behavioral health, the approach to care is comprehensive. Growth hormone therapy is often used to improve height, muscle tone, and metabolism. Careful monitoring and strict control of diet are necessary to prevent obesity and its complications. Early intervention progress such as physical therapy, occupational therapy, and speech therapy. It helps children meet developmental milestones. Behavioral therapy is crucial to manage tantrums, obsessive tendencies, and other challenges, while counseling can support the mental well being of both the individual and their family. Here is the first question of this case. Which of the following is the most likely diagnosis? Select one answer only. Let's rule out one by one. Number one option is Angelman syndrome. Angelman syndrome is genetically related to Prader-Willi syndrome, as both are due to abnormalities on chromosome 15q11 and q13. But the presentation is distinctly different. Angelman syndrome typically present with severe developmental delay, seizures, ataxic gait, and a characteristic happy behavior with frequent laughter. Hypotonia is not a classic feature, making this an unlikely diagnosis in this case. Next option is congenital myotonic dystrophy. This condition can cause hypotonia in infancy, but it is classified as floppy weak, meaning the hypotonia results from primary muscle or nerve disorder. Additionally, it does not cause the dysmorphic features described here. While myopathic fasces may be present in congenital myotoxic dystrophy, but the almond-shaped eyes, narrow nasal bridge, and thin upper lip with a downturned mouth are specific Prader-Willi syndromes. Next option is fetal alcohol syndrome. Dysmorphic features like a thin upper lip and micronathia are seen in fetal alcohol syndrome, but hypotonia is not a classic feature of this condition. Other features such as epicanthic folds and developmental delay can overlap, but the feeding difficulties due to a poor sucking reflex and a specific facial features make Prader-Willi syndrome the more likely diagnosis. Next option is spinal muscular atrophy. This condition can present with hypotonia and poor feeding, but it is another example of floppy weak. In spinal muscular atrophy, tongue fasciculations and absent reflexes are prominent findings, which are not seen here. So, by carefully analyzing the clinical features, Prader-Willi syndrome is the most likely diagnosis among these options. Here is the second question. Which of the following is most likely to occur in children with this condition? Select one answer only. Let's rule out one by one. Cardiomyopathy. Cardiomyopathy is a disease of heart muscle that can cause it to weaken and not pump blood properly. It is not a common feature of Prader-Willi syndrome. While children with Prader-Willi syndrome may develop heart problems later in life due to obesity, cardiomyopathy itself is more commonly seen in genetic conditions like Duchenne muscular dystrophy, where the muscle is primarily affected, not in Prader-Willi syndrome. Next option is poor weight gain during early childhood. Poor weight gain is indeed a feature of Prader-Willi syndrome, but it is only significant in infancy, when babies struggle with feeding due to weak sucking reflex and low muscle tone. However, after the first year of life, these children develop hyperphagia and tend to gain weight rapidly. Therefore, poor weight gain is no longer a major concern after early infancy, which makes it less likely compared to sleep disordered breathing. Next option is progressive respiratory failure. Respiratory issues in Prader-Willi syndrome are typically due to sleep-disordered breathing, not progressive respiratory failure. Progressive respiratory failure is more characteristic of condition like spinal muscular atrophy, where the muscles controlling breathing becomes weaker over time. In Prader-Willi syndrome, breathing problems are more related to brain's control of breathing or obesity. Next option is treatment-resistant seizures. Seizures are not a common feature of Prader-Willi syndrome. They are more associated with other conditions such as Angelman syndrome, which can involve frequent and treatment-resistant seizures, while Prader-Willi syndrome does have neurological issues like developmental delay and behavioral challenges. Seizures are not a defining feature here. Thus, sleep-disordered breathing is the most accurate answer. It's It's an well-documented complication of Prader-Willi syndrome and clear cause related to both brain dysfunction and obesity. Last question. Now the last question. Which is most likely to require replacement during adolescence? Select one answer only. Let's rule out other options. Insulin-like growth factor. Insulin-like growth factor is a hormone that works with growth hormone to help with growth and development. In Prader-Willi syndrome, low insulin-like growth factor levels are often a result of growth hormone deficiency. However, the treatment is growth hormone replacement itself, not insulin-like growth factor replacement. Next option is insulin. Insulin is required for managing diabetes, while obesity in Prader-Willi syndrome increases the risk of type 2 diabetes. Insulin replacement is not a universal treatment for children or adolescents with this condition. Next is thyroid stimulating hormone. Thyroid stimulating hormone is the hormone that tells the thyroid gland to produce thyroid hormones. Some individuals with Prader-Willi syndrome may develop hypothyroidism, which means their thyroid gland does not produce enough hormone. However, this is less common than growth hormone deficiency, and thyroid stimulating hormone replace itself is not the treatment. Instead, thyroid hormone replacement would be used if hypothyroidism were present. Next option is thyroxine. Thyroxine is the hormone produced by the thyroid gland. Some children with Prader-Willi syndrome might require thyroxine replacement if they have hypothyroidism. However, hypothyroidism is not as common or as systematically treated in Prader-Willi syndrome as growth hormone deficiency. Growth hormone deficiency affects multiple aspects of the syndrome, including height, muscle tone, and body composition, making growth hormone the more critical therapy during adolescence. Thus, growth hormone replacement is the most likely therapy needed during adolescence in Prader-Willi syndrome. It has a significant benefits and directly addressing the most common and impactful hormonal deficiency in this condition. Prader-Willi syndrome requires a high index of suspicion in infants with severe hypotonia, feeding difficulties, and poor growth. Recognizing characteristic features like almond-shaped eyes, small hands and feet, and hypogonadism can guide early diagnosis. In older children, the onset of hyperphagia and rapid weight gain are key indicators. A definitive diagnosis is made through genetic testing, specifically DNA methylation analysis, to confirm the absence of active parental genes on chromosome 15. So, early identification is crucial for timely interventions, including growth hormone therapy, dietary management, and addressing behavioral and developmental needs. Collaboration with a multidisciplinary team ensures comprehensive care. That's all about from this case. If you have any question, comment below, like, subscribe, and share.